I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the August 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU. And as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center and Nicole Phillips from the Harvard Plastic Surgery Program. Today we have the great honor of being joined by Dr. Andrea Pusic, Professor and Chief of Plastic and Reconstructive Surgery and Director of the Patient-Reported Outcomes, Value, and Experience Center at Brigham and Women's Hospital. Thank you so much, Dr. Pusic, for joining us for this PRS Journal Club podcast.
Thanks very much. It's a pleasure to be here with you.
A quick reminder, all of the articles that we will discuss can be read for free on PRSJournal.com, including an archive of all past Journal Club articles. The article we'll be discussing is a prospective evaluation of three-dimensional image simulation, patient-reported outcomes and mammometrics in primary breast augmentation by senior authors Drs. Tenenbaum and McCain from the Washington University School of Medicine. To begin, three-dimensional imaging with computer simulation is becoming a more and more popular modality to improve preoperative consultation for patients considering primary breast augmentation. This technology is being used in other areas of aesthetic surgery, such as in rhinoplasty and facelift consultations. The goal of the preoperative consultation is for the patient and surgeon to have a clear understanding of the operative plan and anticipated outcome. Patients are often quite excited about this technology as it enables them to get a nice visual of the surgical outcome. Previous studies have showed a greater than 90% accuracy of computer simulation for volume assessment of breast augmentation, and patients tend to prefer consultation with simulation. However, there are no studies that focus on the impact of simulation on patient-reported outcomes in breast augmentation as measured with the validated BreastQ. The objective of the study was to determine whether the inclusion of 3D simulation during the preoperative consultation improved patient-reported outcomes and impacted mammometrics. This was a prospective trial over a 3-year period with both a randomized and non-randomized arm in which 100 patients were enrolled. Patients agreeing to participate only if guaranteed access to 3D image simulation were enrolled in the non-randomized study arm. The randomized arm was comprised of a control group that underwent tissue-based planning that was supplemented by review of photos obtained from magazines or the internet and placement of sizers in a surgical bra. Control group patients underwent 3D photography with the same system but were not simulated. The intervention group underwent computer simulation with the Vectrosculptor package in addition to control group preoperative evaluation. Inclusion criteria were patients 22 years of age and older seeking primary breast augmentation from the senior authors. Some of the exclusion criteria were if patients had greater than grade 1 ptosis, needed concurrent mastopexy, or could not commit to 6 months follow-up. Patients were administered the preoperative augmentation BreastQ within 1 month of surgery and underwent standard and 3D photography. In terms of surgical techniques, silicone or saline implants were placed using the type 1 dual plane technique. In terms of results, 100 patients were enrolled, of which 1 withdrew and 12 were lost to follow-up. Of the remaining 87, the postoperative image data for 4 and postoperative BreastQ data for 1 patient was missing. 23 patients consented for enrollment in the randomized arm of the study, including 13 that received no simulation and 10 that were simulated. The remaining 64 patients refused randomization and all requested simulation. There were no significant differences between the groups with regard to demographics or implant characteristics. Over time, significantly more patients refused randomization and chose simulation. Interestingly, within the randomized cohort, patients who underwent simulation chose significantly larger breast implants compared to those who did not undergo simulation. By contrast, implant volume in the non-randomized simulated arm and in the entire simulated cohort did not differ significantly from implant volume in the non-simulated patient. In terms of mammometric outcomes, a strong correlation was noted between implant size and breast volume. Change in nipple to inframammary fold distance increased significantly more in patients randomized to the simulated group compared to the non-simulated group, consistent with receipt of a larger breast implant and a greater increase in breast volume. Preoperative breast volume was significantly greater in the randomized non-simulated cohort than either the simulated non-randomized or entire simulated cohort, although there were no significant differences between patients willing to randomize and those that were not. Patients in the randomized simulated group who began with the smallest mean breast volume and chose significantly larger breast implants were noted to have a postoperative breast volume which did not differ significantly from the non-simulated group. In general, however, simulated patients began with significantly smaller volume breasts but did not choose significantly larger breast implants. Analysis of the entire study population with 6-month postoperative three-dimensional data revealed that preoperative simulations significantly underestimated postoperative breast volumes. There were no statistically significant differences between surgeons with respect to any pre- or postoperative manometric parameters. In terms of patient-reported outcomes, there were no statistically significant differences between surgeons with respect to any pre- or postoperative Q-score value. Preoperative Q-scores were not significantly different between any domain regardless of randomization or simulation. Postoperatively, there are no statistically significant differences amongst groups with respect to patient satisfaction with information, surgeon, medical staff, and office regardless of the study group. Further, responses to specific questions were analyzed from the breast Q related to satisfaction with size and implant selection. No statistically significant differences between the groups were noted. Psychosocial and sexual well-being also increased substantially following breast augmentation for all groups, but there were no statistically significant differences between any of them. Overall, I think this was a really interesting study. It's a well-designed prospective study. The authors should be applauded on their study to help further characterize the value of 3D simulation in primary breast augmentation. One potential weakness was their randomization arm was severely underpowered. In their study, the randomized arm consisted of 13 non-simulated patients and 10 simulated patients. In the non-randomized arm of the study, there were 64 patients who specifically opted out of randomization. The authors were only able to enroll a total of 23 randomized patients. This was due to patients becoming more aware of the 3D imaging technology prior to coming in for a consultation and then specifically requested it. This may indicate that patients believe that there is a potential benefit toward the use of preoperative imaging during their preoperative consultation. Another interesting finding within the study was that the simulated patients in the randomized arm selected significantly larger implants than those who did not have preoperative simulation. This suggests that 3D imaging may provide an opportunity for patients to provide greater input during their preoperative visit. Interestingly, preoperative simulation did not result in improved satisfaction scores based on patient-reported outcome using the breast Q. And I want to discuss this further with you, Dr. Pusic, since we have the great honor of having you as our guest moderator and since you're the pioneer of the breast Q. Clearly, the breast Q remains the most robust and validated patient-reported outcome metric for analyzing satisfaction in breast augmentation patients. Items in the breast Q that could potentially capture this, such as quote, how to choose an implant volume that would make your breasts the size that you wanted them to be, end quote, and additionally, quote, understand what you wanted, end quote. Perhaps these items within the breast Q are highly relevant to the potential impact of computer simulation. However, given that breast augmentations generally have very high satisfaction rates, do you feel that the breast Q was not able to fully capture the potential increase in satisfaction with the preoperative consult?
I think you've done a wonderful job of summarizing this article, and I think you really pointed out that it is an innovative study and similarly some of the concerns about its limitations. To the point about sort of what it's measuring and how well it's measuring it, I think the biggest concern here is, as you said, is that there's essentially, because of the difficulty with randomization, which I think probably represents issues within a cosmetic practice, but there was only 13 patients that were not simulated to 72 that were simulated. So that is very much underpowered in terms of being able to make, and there actually is not a power calculation in this study in terms of what would be a more robust approach. So I think we have to be careful in terms of what we say when we're seeing a difference or not seeing a difference. So when a study is underpowered to detect differences, then when you don't see a difference, then we can't draw the conclusion that that difference doesn't exist or that the measurement tool isn't detecting that difference. So I think it's hard to say whether simulation is making a difference because the power to look at that isn't there. I would say, even just looking across patient satisfaction with information, I think kind of interestingly, because the numbers are small, but of the 13 patients, the patient satisfaction with information was actually higher in the non-simulated group by 96 compared to 82 in the randomized simulated group and 93 in the other. So small differences and not statistically significant, again, because of the small size. But if anything, it makes me wonder just a little bit, is there potential that in the simulated group that perhaps with the simulation that the patients were perceiving that the surgeon wasn't spending as much time talking to them, or that some of the more traditional ways that we talk to patients and help guide their expectations expectations that weren't completely as well addressed. But I think that would be a direction for further evaluation and other studies. I would just point out, which I think is a very interesting thing that the authors don't talk too much about, is that simulation aside, that the differences in quality of life and patient satisfaction pre to post-operative across all patients in this study is really dramatic. And so when we think about minimally important differences, which is how big a difference it is in a quality of life score or a satisfaction score, we generally think of sort of a difference of sort of 5 to 10 or greater than 10 to be a large difference. And the change scores here are dramatic. So changes of up to 70 and satisfaction with breast, psychosocial, and sexual well-being are in the 40 and 50 range. So it's not the object of the exercise in this study, but I do think that these changes after breast augmentation, it's been reported by other investigators as well, and it's just something also to convey to our patients, is that I do think that breast augmentation in well-selected patients does have quite a dramatic change in body image and quality of life.
Great. Those are some really excellent points. Francesco, what are some of your thoughts about this paper?
Thank you, Ira, and thanks, Dr. Pusic, for great comments. I really enjoyed this paper, and I thought the authors did a phenomenal job with the methodology and by analyzing both the Mammometrics outcomes and patient-reported outcomes with the BreastQ, which, Dr. Pusic, I hear is a pretty amazing validated patient-reported outcome measure. So kudos to you. But I agree with the comments about the study being underpowered, and we have discussed the use of 3D imaging in facial cosmetic surgery in one of our prior podcasts, and it is interesting how this technology is becoming more and more frequent. So, Dr. Pusic, my question to you is, I was wondering if you do use 3D imaging in your practice, and if you think that it will become a standard of care in breast surgery in the future.
I don't use 3D imaging in my practice, but I do think that it's something that patients find very interesting and it has potential value. So I think, as we evolve, I think it's hard to say, but I do think both sort of in facial aesthetics, in breast aesthetics, and in breast reconstruction, it is quite possible that this, as the technology continues to evolve, it may also just become a patient expectation that 3D imaging would be offered. What the study suggests, though, is it's unclear whether that really makes a difference to helping guide patient expectations and patient decision-making and long-term satisfaction. But I think there's also a factor that it's kind of cool, and the patients, I think, probably really just enjoy that interaction with it. And that's something that, from an aesthetic perspective, is also probably very important just in terms of how practice grows.
Yeah, and I think especially if you're in private practice, it might be that extra thing that you can offer to your patients. It might be it might help you to distinguish yourselves from many other practices. I don't know. I think I agree with you that perhaps patients like the interaction with these 3D imaging devices, and they might like to see the pre-op and post-op. And I don't know. It's going to be really interesting to see what the future holds for this technology. Nikki, what were your thoughts about the paper?
Yeah, thanks, Francesco. I think my major takeaways have already been discussed here. I thought, an interesting paper to look at for a couple of different reasons. We've already touched on the problem of, the underpowered group. And that, to me, is one of the places where we can question, where do we go from here? How do we take this article and make our future research and our future studies better? So, Dr. Pusic, I was wondering what you thought, given this information we have an elective cosmetic practice, we have the sort of constraints of that and randomization, but then we had this huge drop-off in enrollment, after a certain period of time. So what are your thoughts on how we could mitigate these factors moving forward? How could we improve study designs moving forward, given the challenges specifically to this context?
To me, that's the thing that I think is probably the most important point coming out of this article as well, is that we really do need more randomized trials in plastic surgery overall, and particularly in aesthetics. We need to be able to differentiate what's new from what's new and actually better in terms of the care we provide, and randomized trials are an important way to do that. So if ever there's a place that needs more randomized trials, it would be aesthetic surgery, and yet this is a big challenge. And I think this is a great group of researchers, and I know they were very dedicated to this study, but they really did not succeed in randomizing their patients in a robust way. There's different ways, different strategies. I think one is that we shouldn't abandon RCTs in aesthetic surgery because we really need them. I think it's a lot of it, and we've seen this in the cancer world, is that it's a lot of how things are presented to patients. When you think about sort of that we can randomize patients in other areas to chemotherapy, no chemotherapy, and different types of surgery, and yet in aesthetics it is very much more patient-driven. I think that the investigators were successful initially in their study, and so I think some of it may have been how they were messaging it. I'm guessing here, is how they messaged it to patients. But one of the things, so other studies that I've been involved in where we have randomized has been the idea of that to be able to receive this additional potential option, say in this case simulation, that patients are invited to enter into the study, and that is the gateway to potentially having this additional technology or the access to this option in their care. And so I think that what's difficult in aesthetic office is you want to be able to offer everything to everybody, and that drives patient volume. But I think that if we really want to be successful in randomized trials, it probably has to be that when you're bringing in a new assessment tool or a new modality and you want to do a successful randomized trial, the messaging to patients has to be is that, that this is a great aesthetic practice, and we also are committed to research, and we're studying something new. And if you are in this study, then there is a 50% chance that you may be offered this new technology or this new approach. And that kind of has to be pretty solid in terms of patients can't just say, no, I'd rather just have the new thing.
Yeah, so it's a question of making it more of an upfront, as you said, sort of gateway to the study rather than something that comes a little later on in the discussion.
Exactly.
That's a really important takeaway for me. I think the study really points to, as you said, the importance of continuing on with, really robust research in the aesthetic realm.
Ira here. I think those are some really great points. The other thing I was thinking about, we're living in a world where obviously technology is moving at such a fast pace, and before we know it, patients are going to have these type of technology, and they're going to have these apps on their phone that they're going to be able to self-simulate how they're going to look after rhinoplasty or breast augmentation. And one of the pearls we learned early on in our training is to manage patients' expectations. How do we sort of balance the technology reining in patients in terms of their expectations of how things are going to be? It's challenging now, and I think it's going to continue to be even more challenging. Do you have any thoughts about this, Dr. Pusic?
I think it's a good point. It's probably a little bit beyond the scope of the study per se, how you study that, but I do think that, so on the one hand, the simulation, maybe, patients I think can find it very engaging. On the other hand, I think it does potentially, from a surgical perspective, potentially set unrealistic patient expectations. And so I think, like anything, I think it's also understanding what patient expectations are appropriate in your hands as the surgeon. And so a simulation software that says this is what it's going to look like, you have to be very confident that that's truly what you're able to deliver to your patient. And then also how you convey that to your patient is more than just a photo and more than a 3D simulation. I think it's also, there's other aspects to the outcome that patients need to understand as well. If anything, it might raise the bar a bit in terms of how even more carefully we have to manage expectations.
All right. Those are some great points. I think with that, we'll end our discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us for this month for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and is there where our monthly journal club takes place. And once again, thank you so much, Dr. Pusic, for joining us.
My pleasure.